Welcome back to our Vestibular Physician Explainer series, drawing directly from the Australian Dizziness Clinics literature review. Okay, so today we're tackling Superior Canal Dehiscence Syndrome, or SCDS. Now, in the clinical world, SCDS has actually earned a pretty notorious reputation. People call it the Great Otologic Mimicker, and that's because its symptoms overlap so heavily with other common ear and balance disorders. It's incredibly easy to misdiagnose. But getting this diagnosis right, it isn't just about academic accuracy, it's literally about patient safety. So let's dive right in.
There is one diagnostic trap that you absolutely cannot afford to fall into. The literature highlights a truly catastrophic, high-stakes consequence of confusing SCDS with its most common and dangerous mimicker, autosclerosis. If a patient with unrecognized SCDS is misdiagnosed and actually sent for SCDS surgery, it can lead to devastating, irreversible sensorineural hearing loss. It's a well-documented and entirely avoidable harm.
So, the absolutely crucial point to remember is this. Distinguishing SCDS in a conductive hearing loss workup is the single diagnostic step you cannot miss. When a patient comes in with a low-frequency conductive hearing loss, our clinical reflexes usually point straight to a middle ear pathology, right? But SCDS is a third window lesion masquerading as a middle ear problem. We really have to learn how to unmask it.
Let's look at exactly why SCDS and autosclerosis are confused so often. Honestly, when you do a standard symptomatic review, they look nearly identical. Both present with low-frequency conductive hearing loss, both show an air-bone gap on audiometry, both can involve tinnitus, and both often present as a progressive hearing loss in middle-aged individuals. If you stop your investigation right there, you're walking right into the trap.
We can see how deceptive this really is when we look at a preoperative audiogram from a patient with SCDS. The air conduction thresholds dip down, creating a low-frequency air-bone gap of up to 25 decibels. It looks exactly like middle ear pathology. But pay close attention to the bone conduction brackets. They are actually supernormal, falling below 0 decibels hearing level, particularly at 250 and 500 Hz. Since standard clinical audiometry often doesn't even test below 0, this critical clue is frequently missed completely.
Okay, so how do we escape this trap? Well, the critical distinction lies in the acoustic reflex. In autosclerosis, the stapes footplate is fixed, and that abolishes or reduces stapedial reflexes. But in SCDS, the middle ear ossicular chain is perfectly intact. That means acoustic reflexes are preserved and entirely normal. Plus, SCDS patients will often report autophony, hearing their own voice or bodily sounds abnormally loudly, along with the Tullio phenomenon or Hedebert's sign, which are sound or pressure-induced vertigo. Autosclerosis definitely does not cause those.
This brings us to a non-negotiable clinical pearl derived straight from the literature. Any patient presenting with a low-frequency conductive hearing loss absolutely must have acoustic reflex testing before being directed to SCDS surgery. If those reflexes are normal, you have to suspect a third window lesion. VEMP testing and a temporal bone CT become absolutely mandatory before any middle ear intervention is even contemplated. Remember, absent reflexes alone do not confirm otosclerosis, but intact reflexes fundamentally change your entire diagnostic pathway.
All right, let's move to our next major mimicker, Meniere's disease. Again, the symptom overlap here is striking. Both conditions can present with low-frequency hearing changes, episodic vertigo, and oral fullness. And even more confusingly, electrocochleography, or ECOG-G, will often show an elevated SP-AP ratio in both conditions. In Meniere's, we know this is due to endolymphatic hydrops. But in SCDS, the altered paralymph mechanics from the third window actually distort the cochlear mechanics, producing the exact same electrophysiological signature.
Wild, right?
So how do we tell them apart? The discriminators are actually quite stark once you know what to look for. First off, Meniere's produces a sensory neural hearing loss, whereas SCDS produces a conductive pattern. Second, look at the timeline. Meniere's attacks are prolonged, typically lasting anywhere from 20 minutes to 12 hours. SCDS episodes, on the other hand, are highly transient, lasting only seconds to minutes, and they are specifically time-locked to triggers, like a loud noise or straining. Meniere's does not produce sound-induced nystagmus. Now, SCDS also shares specific individual symptoms with a few other conditions. Paralymph fistula, for instance, shares the pressure-triggered vertigo and a positive fistula test. Patulous eustachian tube is actually the most commonly misdiagnosed alternative for the autophony symptom. And superior canal BPVP shares the exact upbeat torsional nystagmus pattern seen in SCDS. Stripping away these final mimickers really requires targeted questions and testing. A paralimb fistula typically follows a specific acute event, like barototrauma or head injury, and crucially, it lacks the autophony and the characteristic VEMP thresholds of SCDS. For a patulous eustachian tube, just ask the patient to lie down, their autophony will dramatically improve in the supine position, whereas SCDS autophony shows no consistent postural change at all. And for BPPV, the nystagmus is strictly provoked by position, not by sound or pressure. Plus, both PET and BPPV will yield completely normal VEMP and CT results.
Let's look a bit closer at those VEMP results, because they really anchor the diagnosis in definitive physiology. With a cervical VEMP, or a C-VEMP, the threshold is significantly reduced to 65 decibels or lower, which indicates a pathological acoustic hypersensitivity. Meanwhile, the ocular VEMP, or O-VEMP, shows a markedly asymmetric and elevated amplitude on the affected side. Essentially, the third window lowers the resistance for sound and pressure waves, and that results in these exaggerated, pathologically lowered vestibular thresholds.
Once the physiology strongly suggests a third window, we have to confirm it anatomically. This requires the absolute gold standard in imaging, a thin-sliced multi-detector CT of the temporal bone. And critically, it must be reformatted in 2 planes. Specifically, looking at reformats in the pushal plane, which is parallel to the superior canal, is essential. Relying only on axial planes substantially increases the risk of partial volume averaging artifact, meaning you could easily miss a true defect or even diagnose one that isn't really there.
All of this evidence builds into a highly actionable summary cheat sheet for differential diagnoses. For otosclerosis, the key feature to look for is absent acoustic reflexes. For Meniere's, it's a sensory neural loss coupled with long attacks. For paralimb fistula, you're looking for a history of trauma without autophony. SCDS is the only condition combining intact reflexes, autophony, and the Tullio phenomenon, which is then confirmed definitively by VMP threshold reduction and CT evidence of dehiscence. If you take away just one clinical concept from this entire explainer, let it be this triad. While various parts of SCDS mimic other diseases beautifully, the simultaneous presentation of the Tullio phenomenon, autophony, and a low-frequency conductive hearing loss points exclusively to a third mobile window. When you see this specific combination, the diagnosis of SCDS must be systematically ruled in or out.
Now that we've successfully unmasked the great mimicker and secured the correct diagnosis, where do we go from here? Well, in the final explainer of this series on management and prognosis, we're going to complete the clinical journey. We'll review everything from conservative behavioral avoidance strategies right through to surgical repair, helping you set realistic, evidence-based expectations for your patients. Thank you so much for watching this explainer in our Vestibular Physician series. Misdiagnosis carries profound risks, but with the right discriminatory framework, those risks are entirely avoidable. To explore more topics regarding dizziness, vertigo, and imbalance, and to access our clinician and patient resource materials, please visit AustralianDizzinessClinics.com. If you found this structured breakdown helpful, go ahead and subscribe and leave a rating. I'll leave you with this thought. The very next time you see a routine conductive hearing loss, will you remember to check the reflexes? See you in the final explainer.